Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor for ACO Exhibit Hall, and I would like to welcome you to today's webinar by Roji Health Intelligence called How ACOs Can Position Themselves to Compete in a Direct Contracting Environment. As you all know, this is a very hot topic right now, so there should be some great discussion here, and there will be some time for some Q&A afterwards. A couple items of note before we get started here. All attendees have joined today in listen-only mode, so don't worry about muting your mic. That will be done for you. And I'd like to let you all know that the webinar is being recorded so that you will have an opportunity to rewatch it and or share it with colleagues and go back and reference it again. I'm sure a lot will be covered today. And a link to the recording will be emailed to you following the presentation. So I'll reach out and send you a link. And that's also where, by the way, you can download the slides. During the webinar, during the webinar, you'll be able to submit questions to our presenters, which I'm sure you may want to do, using the attendee control panel, and we will answer as many of those as possible in the Q&A session at the end, and you can submit those at any time during the presentation, and then we'll get to, again, as many of those as we can at the end. If your question is unable to be answered during the allotted time, we will make sure to follow up and answer it via email afterwards. So please go ahead and ask it anyway. And without further ado, I wanted to introduce our presenter today, Ms. Teresa Hush, who's the CEO of Roji Health Intelligence. Welcome, Terry.
Thanks so much, Garrett. I'm Terry Hush, CEO and co-founder of Roji Health Intelligence in Chicago. And well, thank you so much for joining this very hot topic on ACOs and direct contracting. I have a lot of content to present today, so I'm going to work fairly quickly through it and not linger on a lot of issues, but if you feel free to ask those questions of me, and if I don't get to them, as Garrett said, I'll be glad to answer them afterwards. So one of the big issues, of course, that we're facing is that the church that was built on accountable care organizations is facing a lot of stormy weather right now. Now that they're not the only plan that's being backed by Medicare, then how do ACOs work out a future that is profitable for them and for their providers? What we'll talk about today are a lot of the nitty-gritty of that. So what do the Medicare value-based payment models and the shifting priorities say about the future? What's the real competition to ACOs? Is it the direct contracting entities or something else? Does Medicare's direct contracting effort hurt or help ACOs? You may already have an opinion on that. What arrangements are open to ACOs in direct contracting? What's the best game plan? And what do ACOs do to pursue a path to be competitive and relevant? So let's talk a little bit about what we won't address. What we won't address is some of the topics that are out there in the fabric of the ACOs and are very concerning. The DCE cost benchmarking and capitation formula, for one, the risk adjustment formulas, the infrastructure requirements for DCEs, and how to hold on until the last moment. I want to give a little bit of my own background because I'm going to be discussing a lot of strategic issues that come from experience that predated Roji Health Intelligence, and I want you to be aware of that perspective because it comes from a lot of solid experience both in government, managing a very large entitlement program and health benefits, and then being in the provider community, managing health system initiatives and a fully capitated risk environment in which not only were the primary care physicians capitated, but the specialists and hospitals were also capitated in that environment. I also spent some time at United Healthcare where I experienced the stratosphere of Medicare Advantage and more specifically the local Medicare Advantage products. With co-founder Tom Dent and I, we worked together at the health system. We founded ROGI because we saw what was coming in value-based care, then called pay for performance, and we knew what providers needed in order to make a go of it. And since 2002, we've been doing that. So from Blade Runner, I will start. I've seen things you people wouldn't believe in those environments. And so my perspective is informed by those kinds of experiences, and you may be a little surprised to hear some of those things. Don't kill the messenger because of it. It's just a perspective, and it may turn out quite differently, but my understanding of how CMS is moving forward says it comes from my experience in managing budgets, managing a Medicaid program, and seeing the writing on the wall related to costs. So we've got a busy landscape. Right now, there's Medicare Advantage, the ACOs. I'm not including in the value-based landscape the ACOs that don't have downside risk, because we know that they're all headed towards downside risk. The next generation ACOs, direct contracting, primary care first, CPC plus, the various specialty care models like cancer and bundled payments, and that's just the beginning, I believe. Of those, Medicare Advantage plans have seen the largest growth among enrollees. And why is that important? Well, it's capitated for Medicare, which means it represents a fixed cost. And that capitation is being moved downstream to providers. That aspect of Medicare Advantage plans is growing so that many providers in many of the larger plans are now being capitated for their own patients. Patients actively choose to be in an MA plan. That's also significant. And I know that the lack of that active choice is a process that ACOs are trying to wrestle with. CMS publicly praises Medicare Advantage, gives them special benefits that nobody else has. And more importantly, it's referenced Medicare Advantage as an alternative to provider-based models. Can it be the Medicare's alternative plan for capping and privatizing Medicare? Very possible. The bottom line is that CMS believes that Medicare Advantage is its prized cost-effective tool. And as it moves risk downstream to providers, it will pose a choice for providers who are not protected by their own entities and managing their own risk. And that choice is you either get risk through Medicare Advantage or you get risk through your own DCE or ACO. CMS is on paper, and we all know how it has challenged ACOs to evolve. It pushed the downside risk and pathways. It challenged the model effectiveness through MedPAC. It's now offering an alternative view of next generation results. Whether that's valid or not is not the question that we can ask right now. What it says about Medicare is more important. It says they don't believe it. It's developed alternative models for providers unwilling to participate in ACOs. That's what the DCE originally started out being, was a primary care model that was focused on providers who were never going to be in an ACO, or that's what was said. So far, it's held ground on payment models on the next generation term, and it frequently and publicly targets the fee-for-service payment model. The bottom line is the support is contingent. It's contingent on ACO success in capping costs through risk and a change in the payment structure. And I would want to emphasize that fee-for-service has been a target of Medicare, and particularly this Medicare administration, since its inception, and they want it to be gone. Direct contracting has become a way for CMS to achieve objectives for ACOs and to move them beyond the fee-for-service model and off the shared savings model into a fixed cap. So in my past life, if you really want to shake things up and move change, you do a lot of stuff all at once. And that's what happens when you have multiple models. They force change. They force attention of the constituents on which way is this going and starting to think about how I can grab the opportunities before they're gone. Direct contracting forces ACOs to compete for patients. They either compete with their own groups who may be more competitive or pro-risk, or they'll be competing with other ACOs who are DCEs and can lower cost. Either way, it's a gamble, but it's a model that forces change. A change in payment model built on voluntary adoption of capitation. I mean, nobody thought this would happen a few years ago. But here we are facing what was live in the 90s. It forces providers to scramble and consider the future. So does it help or hurt ACOs? By the way, that's the New Zealand thermal pool that we should all be, it's kind of hot there and a little stinky. Direct contracting changes the goals and the rules of the game, and I'm going to spend a little bit of time here, but I'm going to go through a lot of this later too. So the leverage here under direct contracting is patient volume. It's not, the goal would have to be to increase patient volume to provide more competitive leverage. Where is that competitive leverage needed? It's needed to control the costs by negotiating with downstream providers. If you don't have competitive leverage through patient volume, your ability to cap other providers' costs, your preferred providers, is limited. A second goal is long-term patient care cost decline. It's not short-term. So the ACO world is a year-to-year savings from the prior year or historical spending. That's not the game under capitation. The only way that you can contain the costs and get a profit under capitation is to change the long-term cost curve. And that is a very different programmatic goal. It implies different kinds of processes for an ACO than managing costs or dealing with short-term cost overruns, or even dealing, for that matter, in things that will have a one-time savings opportunity. So you can get by doing one-time savings things now, readmissions, post-acute services, and so on. But in the long run, that won't work. It has to go into the overall spending on a per-patient basis. To do that, you'll also need younger and healthier patients to come into the ACO. It means that the organization will have to be built not only for Medicare, but to reach out and contract with health plans and employers directly, because that's where the younger patients are. It will also have to, because Medicare Advantage is skewed towards younger and healthier patients, it will have to appeal to the Medicare crowd who are younger and less risky. Containment of primary care leakage outside the system, which we know generates over $10 per member per month in extra costs, is essential to that. It means, and what does that mean for your activities? It means that your connection with the patients and consumers under direct contracting is an entirely different relationship than a coordination of care model. It means you're appealing to them. Referrals have to be selective. There won't be a way to make money on capitation unless referrals are selective and you're controlling the costs of your preferred providers as well as yourself. To pay your own physicians a capitated payment and pay providers who are specialists fee-for-service won't work. Won't work. So there will have to be a negotiated arrangement between every major specialty, and it will have to be made on data terms to be able to be successful. So let's go through some of the options of yes or no be a DCE. So ACOs who choose not to be a DCE, they may lose to competitive groups. They may lose their own groups who will defect because they want to compete, or they want more patients, or they see the ACO is riding off into the sunset. Small ACOs will be challenged by the resources of capitation. They will have to have a lot more resources in order to brand and keep patients and do all of the things that I'll outline later to be a part of capitation, or they may need to merge. Consolidation in the provider market happened because there was a perception that strength was in numbers. Now that strength was eked out in a different way than in a capitated environment, but the same premise holds. It's numbers that will contain the leverage under capitated environment. Large hospital-based ACOs, if they choose no, they'll eventually lose their market share and their patients will gravitate to Medicare Advantage because their value will not be lower costs, transparency, customer service, and the things that patients want. ACOs may also lose their own primary care physicians. Those primary care networks are already challenged by fewer physician owners, less independence, larger practice sizes, more hospital-based owners, and a growing amount of primary care physicians in large multi-specialty groups. If they choose yes to an ACO DCE concept, but they want to do partial risk, it will limit the opportunity under DCEs. The resources will be limited by partial cap. Without being able to negotiate downstream care with specialists and hospitals, they'll have a reduced opportunity to be relevant to those specialists and therefore be able to cap costs. So they won't see the opportunity in growth. Partial risk DCEs will remain administrative, unbranded entities with poor growth prospects. And regardless of whether an organization chooses to be partial or global risk, the infrastructure and people costs will be a factor, either way. But only global risk provides the opportunity for competitive positioning. And that's if the ACO has the right alignment with its participating providers and has the structure it needs to create the long-term value for patients. So just looking at a couple of the different permutations of direct contracting, what's available to ACOs, they can be the DCE entity, they can be an MSO to multiple DCEs. Perhaps an ACO right now is comprised of groups that would like to be directly contracting, but the ACO itself can't do that. The ACO does have an infrastructure already that's moved and that's created some value for the participating providers, and it could continue to do so. Groups in the ACO can be DCEs without that kind of MSO arrangement, and then the ACO would eventually lose its providers, or its most valuable providers, and would dysfunction. And then, of course, the DCE risk level, partial risk, global risk, eventually geographic risk. Those decisions by the ACO will determine how it is positioned in the market. With global risk can come growth through risk contracts with commercial plans and direct employer contracting, and we see that as a major thing happening in the market right now, particularly employer contracting. Branding, patient marketing, and retention get a big boost under DCEs because they have a more visible presence. They have a real alignment or a stronger alignment than the current attribution model under ACOs. There are resources that are provided to DCEs to be able to do the kind of thing that they need to do. And their decision will determine whether the focus continues to be an administrative entity that works behind the scenes to control costs, or whether the DCE takes on an image and a brand as a healthcare entity and bonds with patients. So what do they need to do if they pursue this kind of path? The 5 issues you must take on to compete are not the things that might be on your list right now. One is consumer loyalty and customer service, medical decision-making, data and technologies, but that's probably on the list, changing physician roles, and referral arrangements. So I'm going to go through each of these. Oops. Okay, consumers and patients. So providers generally refer to their patients as patients, of course, but most patients now consider themselves consumers. So what's the difference? Consumers make purchasing choices. They're free entities. They consider themselves in a buying relationship, in a bilateral relationship with their providers, and in a decision-making capacity, and that decision-making capacity needs support. In order to brand and deal with patient loyalty as a long-term DCE, ACOs will need to create that kind of material between themselves and the patients. They will need to change their mindset about who their consumers actually are. Who are the customers? Are the customers the physicians in the plan? Are the customers the Medicare, for example? Not anymore. With as much anger in the consumer community, and as much as politicians and healthcare has become a major issue, the major customer has to be seen as the consumer. And that the loyalty of that consumer is paramount under a capitated model. There has to be a choice for that consumer to be willing to be bonded to you and not see other providers outside the tent. There's no engaging a patient who's already annoyed. If they've spent four floors going through the parking garage of all reserved spaces for physicians, they're already annoyed. If the front desk staff is putting them on a wait list for an hour before they see the physicians, they're already annoyed. And if they had to call repeatedly to make the appointment, they're already annoyed. So what does the organization do to help its providers further the goals of customer service? That's going to be a key question for ACOs who want to get into this arena on a capitated basis, because you can't afford to lose the patients, especially those who can walk. And those people who can walk are going to be the younger and healthier ones, not those who are destitute and need you because you're the only one who will see them. In that arrangement, the physicians need the time and support to communicate with those patients. Running the kind of throughput that we see providers do under fee-for-service because of the volume demands on fee-for-service, it just won't go under capitation. The incentives are different, for one, so more things need to be covered with a physician or other staff, and that time needs to be budgeted and really carefully examined in physician compensation plans and all the way down the line where it exerts an influence on what is happening between the patient and the physician. Transparency of cost. If patients are going to be paying for their services, and they're going to be sued by hospitals for not paying their services, and they're going to fall into an area where they're in financial distress, it won't take long for them to flee to a Medicare Advantage plan that promises them they'll never have to do that. Patients also want to decide more than providers really understand about the evidence for their treatments as well as the cost of that treatment. They have decisions to make. It's not just the patients who are medically illiterate. It's everyone who really wants to know what is the value of this. And we all know that there are many services that continue to be performed that have questionable medical evidence behind them, but we still do them because we assume that the patients are demanding them because they think they're of value. And that has to change in order for the cost curve to change. If you're an ACO that's been working on spreadsheet technology, that's not going to work. There's going to have to be artificial intelligence, or will have to be a lot of testing of the paths that really produce the best outcomes and costs for patients. There won't be any possibility of examining referral costs on a service-by-service or even a procedure cost basis. It doesn't work. You need to know all the inputs into care before defining what the cost of that care is. And looking at this kind of detail by spreadsheets does not even begin to approach what's needed. Many sources of data will be necessary. So it starts with claims. Claims is a good way of knowing what you've spent and where it's gone. But it doesn't end with claims, because if the job isn't to make the patient better and a better long-term cost for you that comes under the capitation level, then it's going to cost you. And that cost will not be reimbursed because it'll fall over the cap. So I'd just like to take a look at, really briefly, a bunch of data that is needed to drive DCE interventions in all the different categories. A lot of these organizations have been working on right now, but what they haven't really been working on very heavily are referrals. And many of ACOs don't have the kind of cost methodologies that really look at episodes, predictive costs in a way that is beyond actuarial, but that is individual. Lots of different data sources here to collect. Another area is medical decision making. So what do I really mean by that? The strongest intervention that you can make is for a patient to seriously weigh what their treatment plan is and how to comply with a treatment plan that is going to work. And that means that the physician time for reviewing evidence and goals to guide that process will be paramount, supported by staff, and that there will need to be an organizational support for creating materials, because we cannot expect physicians to pull down research that is not accessible currently to patients and give them the evidence. That has to be done by the organization to make it work. Transparency of cost in that process, and I mean transparencies of episodic costs. So if a patient is considering a procedure, the episodic cost is what matters, not the procedure cost. And they need to understand that everybody is in the tent of the DCE, and the DCE needs to ensure that that's the way it works with its referral arrangements. Physicians are going to need help with their changing role in this regard. Physicians are used to being able to make decisions, saying this is how we're going to do it. And in an environment where consumers are making choices that they're paying for, that's not the way consumers want it to work. They want to have a say in that, and they want to pursue things that are effective for them and that they're willing to pay for. So it's a very different kind of arrangement for physicians. It's different culturally. It's different in motivation and how the organization deals with consumers on multiple levels to get them engaged and interested in healthcare, not just compliant. Physicians are not really on a positive path for DCE growth right now. Many of them don't want Medicare patients. Many of them don't like medicine at all. Many of them say they're overworked or overextended, plan to retire, reduce hours. So they're not happy. In order to provide for physician engagement, and I mean positive engagement, physicians will have to be approached in a different way than organizations have historically approached physicians in health systems and in some ACOs. I mean, of course, it differs across the board. They will have to be approached through data and learning, and they will need to see sample data sets that are relevant to them without a lot of work, but they need to be have a better understanding of what they're actually seeing and what's driving the initiatives that they're involved in and how they're being evaluated in that organization. So let's look what they want. And this is coming from all the surveys about what physicians say they want. They want an understanding of risk and choice. They want the extra resources to support their work. They want more patient-facing time. So this is something that both patients and physicians agree. They want the data and information for medical decision-making, and they want to see patient costs and outcomes. A lot of organizations don't really provide that kind of information to physicians, and here's an example. So when physicians are asked what they consider important and what they get, 72% of them consider cost data to be very important. Only 28% of them actually get it. That's a gap that needs to be filled as we move into a capitated environment. Physicians have to be part of the infantry of the DCE and complete partners in the process. On the specialty referral arrangements, DCEs can no longer depend on historical patterns of referral to ensure that their patients are cared for. There needs to be a better stratum of understanding about the care that's delivered by the specialists, about how to cap costs from those specialties, about the communication back to the primary, and about the outcome of those patients. Right now, in many cases, it's just a complete blank. Negotiation with those providers will be dictated by the leverage of the DCE and the relative importance of the preferred provider group in the community. Many groups have no competition. They have very difficult time working with specialty groups and on a competitive basis because there's nowhere else to send the patients to. So that will have to be worked out. It's a difficult arrangement at best. It has to be on a partnership level to make it happen. Episodic cost data and volume will be essential to that. No matter what the relationship is, even if the organization will have to pay preferred providers on a fee-for-service basis, if they're lucky, maybe can get a withhold, they will still have to share data on the episodic cost data and volume so that they can look and help those providers understand their dilemma. Primary care physicians will have to be involved in providing feedback. They'll have to get and collect patient feedback on their outcomes. There needs to be a loop back process so those patients are back at the primary care physician within a certain amount of time after seeing a specialist, so that the physician, even if they're getting a report, which doesn't always happen, they are seeing what the patient says about that service. And they'll have to provide coordination and communication score of some sort so that the organization can track the viability of those referral arrangements long term. So it's unlikely that Medicare is going to change the course on risk, regardless of what happens. So if we've been looking at all the alternative healthcare plans out there, if anyone watched the debate last night, I don't think there's a holdout. And why is that? Well, because one is the budget situation is becoming desperate. It doesn't take too long looking at the numbers of the Medicare fund to see that it's going to be exhausted soon. And I think that's why this is ramping up. Second, the U.S. healthcare costs have become a focus for everyone. Consumers, politicians, providers, business, everyone is on the same page about lowering the cost somehow. Fee-for-service has been a long-term target. It's not new that people are pushing for an elimination or change in the payment structure. But it's the first time that actual proposals have been on the table to do it. And then provider consolidation and better data has made this possible. The fact that there are providers out there and ACOs that have developed good plans and strong frameworks and foundations for moving into risk is a testament to how well we have come, or how far we've come in the last couple of years. So it's a realistic goal to move into a DCE environment. It's going to be a lot of work. The final line here is that ACOs and other groups can succeed as DCEs under risk, but it requires change, and that change will come heavy and fast. But it will benefit the organization, providers, and patients. We're here as ROGI. We'd love to help organizations that are willing to take that plunge or at least inch into it and help you with solutions that can get you there. But the fact is that the world is painted in a way that is going to move into a capped environment on cost because there doesn't seem to be an alternative that's working. And so as the payers align on that, and they're beginning to be aligned, you see Medicare, Medicaid, the health insurance sector, as well as consumers, all complaining that they can't afford it. So we will see that cap. And the question is, do we control our future under that, or does it become part of the insurance industry? And I think we're open for questions.
All right. Well, thank you, Terry. This was very informative. And we do have a number of questions that I wanted to ask today. Okay, the first being, and these are in no particular order. First of all is, how do we persuade our physicians to accept direct contracting compensation if we don't know what exactly CMS is going to pay DCEs?
Well, you won't have to make those decisions first day out. Some of the clarity will be involved by time. And I think that CMS will begin to make clear the overall level of that compensation. So if it is on a primary care basis, a rough estimate is going to be looking at your own claims data and seeing what the total cost of care is minus the withholding plus administrative costs. It's not a hard process to examine a ballpark figure of what providers will be paid, and then to shadow how that compares on a per provider basis with their revenues. In order to do that, you would have to have the provider data as well as the claims data. But it should be, it's not a hard process to do in a ballpark way.
Okay, great. The next question is, younger and healthier patients are essential to financial success as a DCE, but MSSPs benefit from having sicker patients for higher benchmarks. That seems like a complete reversal in membership strategy, right?
It sure is. It sure is. Yes, it is. And that's why I really deliberately put that in there, because as a capitated entity, the only way it can really survive under fixed costs is to have a balance of risks in that entity. And so it's not a year-to-year cost scenario with members who are sick. It's about making sure that you've got a balanced portfolio of your patients so that you can weigh the risks. There are always going to be patients who are not going to do well, and there will always be train wrecks.
Okay, the next question is, will the DCE capitation versus data and approvals needed for filing claims meet the desire of physicians to have more time to spend with patients and less job demands?
I'm not sure I understand that. Can you repeat that?
Yeah, sure. Will the DCE capitation versus data and approvals needed for filing claims meet the desire of physicians to have more time to spend with patients and less job demands?
Less claims.
Yeah, there won't be as many claims. But you want to, I'm having trouble, I'm still understanding.
Okay.
There's a sense of that the physicians are somehow involved in the claims process and the filing of that data. There won't, the physicians will still be using their EMRs. They'll still be those will still be punched into the system as billings. There will still be a billing process in order to capture the data. None of that will change under a capitated environment. None of it. But what will change is the kind of incentive that an organization has to rush patients through the process. And it will most likely employ more navigators, more nurses, and more other secondary staff to facilitate a decision-making process with the physician. Does that answer the question?
I believe so, yes. Okay, let's move on here. This was more of a comment that came through, but it says, appreciate the a quote soapbox expressing the existential threat to current practices and arrangements. Would you like to expand on that a little bit more?
The existential threat?
Existential threat.
Capitation is an existential threat. Yeah, I mean, I've created several existential threats. One is that Medicare will walk and put everybody in Medicare Advantage, right? The other one is that capitation will come down hard and heavy on everybody, whether you like it or not. So there are several existential threats out there that I think will slowly become into reality if there are no changes in the system. So what we see in the current environment is a response to a fee-for-service delivered system where we still have a managed care negotiation of rates among health plans and employers. But when that shifts to a capitated environment or employer-based contracts, or and a variety of things are emerging right now, you will begin to see it eke out in those systems. One of the things that's happening is physician equity groups, as we all know, have a very heavy footprint now in many of the specialties. Dermatology, they're making headway in anesthesia. Ophthalmology is largely moving towards physician equity, and I see that happening. You see some of it happening for capitated specific environments, like Oak Street, for example, is an organization that's staffing physicians specifically to be under risk. That is going to increase. Those entities, the IPAs of old, if anyone still remembers the IPAs of old, will come back. And there were organizations under that, physician practices, that were enormously successful in managing high-risk Medicare patients.
Great. Well, very good. And that concludes our questions for today. We did have a couple of actually comments that came through. Said very much appreciate your perspective, and thank you for an excellent presentation on a critically relevant topic. And I truly agree. I think this is a very timely, very relevant discussion. So thank you, Terry. And again, for those of you who maybe still have questions and that we were not able to get to today, or you need to kind of mull it over, we would encourage you to reach out to Terry. We'll give you her contact information, which is actually down at the bottom of the slide right now. As we conclude, I'd like to encourage you all to visit the ROGI Health Intelligence exhibit booth at ACO-Exhibit-Hall.com and learn more about them and connect with their team. And this is also where the recording of today's session and the slides will be available for download. You'll be able to get that. So on the screen, you're seeing the ROGI booth, and this is where, again, you can connect with them and learn a little bit more about what they're doing, meet their team. And you will find the recording in the ACO Exhibit Hall reference library, as well as these slides. Okay, lastly, if you have any specific questions for Ms. Hush, her contact information is here on the slide, and feel free to make a note of that and contact her directly. And she'll be happy to follow up with you for any further discussion. And also Dr. Dent, who's the president and medical director and co-founder of the ROGI Health Intelligence, who's also on the line, is also available for you. So thank you all for attending. I'm going to leave this slide up here for a few minutes so that you can get down this information. But I hope that you found today's presentation informative and very helpful, and hope you have a great rest of your day. Thank you for coming.
And thank you so much for listening.
All right, take care, folks.